What goes up and never comes down? Goes up and never comes down. Your age. Where do crayons go on vacation? Where do crayons go on vacation? To the wax museum. What does a nosy pepper do? What does a nosy pepper do? Gets jalapeno business. Oh, that's pretty good. Pretty good. Y'all ready for some rain? You think they're lying, or is it going to rain? Yeah, but I thought it was like hurricane level today, and I haven't seen anything. So, all right, let's have it wait for class to end and us to comfortably get into our sweatpants and have hot cocoa and tea. Sound good? I like that. I like that plan, actually. Sounds good to me. Okay, looks like we have a brand new computer. So your IT fees at work. Okay. I'll just leave it at that. Okay. Hypersensitivity in autoimmune disease. We're going to finish this out, and then we're going to get into some primary and secondary immunodiseases. That'll be the second half of today. So we're kind of wrapping up what we introduced on Tuesday. And before I start, so there was a question about reviewing exams. So the quizzes are open after you take them. The exams, we need to make an appointment or come in into office hours. So I don't just open it up because I don't want those questions sort of circulating on AI. Okay. So just kind of an update from Tuesday. But as we get into it today, we're going to kind of focus on type 3 and type 4, some examples, some very specific examples. And transplant rejection is a type 4. So transplant rejection is a type 4 hypersensitivity. So remind us, what is hypersensitivity? Just kind of recap for us. What does that word even mean? When we talk about hypersensitivities, what are we talking about? An overreactive immune response to some sort of, I'm going to call it an antigen. Okay, because it could be an allergen. You're not incorrect. But in the case of type 4, it's not a allergen. It's an antigen. It happens to be an antigen that's in tissue, and that tissue is being seen as being foreign. We'll get into some other examples of that tissue is actually you know, from your own tissue, and so you're going to attack your own tissue. Okay, so really well done. Did you have anything else to add to that? Hypersensitivity? An overreaction or being overly sensitive to something? Yeah. Is it a typical response? Hypersensitivity would be considered a normal physiologic response. No, I would agree. Would it be considered in the category of a negative or a positive feedback loop? Positive feedback loop. Pathological though, right? Because we just got done talking about how it's not normal physiologic, like labor contractions or blood clotting or some of the other examples that we talk about. Okay, so if we look here, we've got incompatibility to the allograft. Allo meaning same, allo from the same species, but it's a different individual. And so there's a compatibility mismatch. The example that we're using here is a kidney donation. So we're at the very bottom, we're looking at the renal tubules and the renal blood vessels. So this is a kidney being donated from one patient to another. And what is the supposed antigen in this circumstance? What's the incompatibility? What's the mismatch that your immune system sees from the donated tissue? MHC complexes. Very well done. MHC complexes. Do you want to raise that a little bit so it's not like smacking you in the head? You can. Or maybe you can't. It might be the other string. Oh, yep. We're getting closer, though. We have success. Perfect. Hey, that way you're not like, it's not bothering you. Okay. So MHC complexes. Now, the idea is that you're going to recognize the MHC complex, or you're going to recognize material or tissue as being foreign. And so we can either have a direct pathway or an indirect pathway. The direct pathway is the pathway that's kind of shown and highlighted on the left, and the far right is the indirect pathway. And so let's just walk through this just real quickly. In the circumstance of the direct pathway, the antigen presenting cell is in the graft. It's in the donated tissue, and it's presenting either an MHC class 1 or 2 to the recipient's immune system. So that's a direct pathway where the foreign material's antigen is being displayed, okay? And what's being displayed is really the MHC 1 or 2, just like what we talked about. That should make a lot of sense. That's direct rejection, okay? On the indirect pathway, the recipient, excuse me, the recipient, the host, the one that actually gets the tissue, that immune system discovers cells that are from the graft and identifies those cells as being foreign and is displaying it on its own MHC molecule, but displaying it to a helper T cell, saying, look what I've discovered. This is an indirect pathway because the tissue that's being donated isn't directly causing the problem by displaying its own MHC. It's discovered by your immune system or the recipient, and as it's discovered, it takes a little bit longer, so we would say this is more of an indirect recognition. You understand the differences? It's subtle. It's a very subtle difference. If we look at the direct pathway, we ramp up our CD8 or our cytotoxic T lymphocytes very quickly. They come in and they attack the donated tissue blood vessels in the kidney. They also attack the renal tubules directly, attacking that foreign material directly. That's the direct pathway. The indirect pathway is a little bit more kind of side door or a roundabout sort of way, where you stimulate helper T cells. The helper T cells ramp up an inflammatory response that has a very similar eventual reaction, which is causing inflammation in the blood vessel or a vasculitis that takes place here. This one's called an endotheliolitis. It's kind of the same terminology. Endothelium is found in the blood vessels, so an endotheliolitis is just targeting the endothelial cells, but a vasculitis is just more general term, saying it's just the blood vessel itself that's being inflamed. So really no difference between endotheliitis and vasculitis. It's kind of a similar result. And activated macrophages get recruited. They also attack and stimulate an inflammatory reaction in the renal tubules themselves of the donated kidney. The other thing that happens is the helper T cells turn on the production of B lymphocyte antibodies, and those antibodies help to stimulate this rejection. Help in air quotes, right? Because it's not really what you want to have happen, because you want to do the transplant, but this is how the immune system is going to respond. Okay, so incompatibility of the allograft. So one of the ways that we try to manage this is we manage this using immunosuppressant drugs. So immunosuppressant drugs, for example, like cyclosporin. Sorry, they took away the last monitor had like USB ports in the side, so that was kind of nice. Cyclosporin, if you recall back to T cell activation, cytotoxic T lymphocyte activation, what was the significance of the interleukin 2? What did we need it for? What's that? It's not complement, but it's a word that starts with a C. Co-stimulation. Yep, you're kind of close. So the co-stimulation, what is co-stimulation? Where IL-2 is being released and then binding back onto the same cell that released it. What does that co-stimulatory event do for these CD8 positive T lymphocytes? It's an autocrine response, you're totally right. It's co-stimulation to make sure that you want to activate that cytotoxic T lymphocyte. You were thinking, now I know why you said that. You were thinking about antibodies and B cells, and the co-stimulatory requirement there is a complement. Oh, yes, yes. So if it's B cells, kind of review, B cells, the co-stimulatory event is complement, because complement is upregulated during an inflammatory scenario where the liver is making more complement, saying, hey, inflammation is ramped up in the system, I need to be ready. So the complement is circulating. So if a B cell gets activated and there's complement on board, that's the co-stimulation event on the B cell side of the equation. But on the T cell side of the equation, it's IL-2. So cyclosporin is very effective at blocking the production of interleukin-2. And so it's considered a very potent immunosuppressant drug used post allogenic organ transplant, like a kidney, like what we're talking about, but also skin transplants, heart transplants, lung transplants, liver transplants. Cyclosporin is kind of one of the main go-tos. So giving you sort of this explanation as to how we can manage the immune system if we do need to donate tissue. Let me just finish, and then I think you have a question because I might answer it. So if a patient receives a donated organ and it's deemed that they need to be on immunosuppressants, how long do they need to be on immunosuppressants? Huh? Forever. For the remainder of their life. It's a pretty big risk to try out like coming off of them and seeing what happens, right? So yeah, lots of side effects associated with this for in obvious ways. Joseph, did I answer your question or did you have another one? Yeah, I read your mind. I'm not a mind reader. I just done this a couple times, so it looks like it. So this is a picture of the progression of rejection. Okay. So boy asks girl on the left, girl says no on the right. Rejection. Okay. Far left is a kidney glomerulus. And the first panel on the far left of hematoxylin and eosin, this is hyperacute rejection of a kidney allograft. So we're setting this up, right? This is where we have the buildup of sort of the story that's unfolding from left to right. So you've got endothelial damage, platelet and thrombin activation. So you see the clumping, like the dark red that's starting to clump. If you look closely at where the blood vessels are, you'll see the loss of integrity of the endothelial lining. So hyperacute, very early phases. Acute cellular rejection is the next panel, panel B, just to the right of panel A. And here you've got a tremendous number of inflammatory cells. These cells are neutrophils, so they're the first responders, if you remember back to the inflammatory lecture. So these neutrophils invade, and they occupy the interstitium between the epithelial cells of the tubules and the tubule lumen. And so what I'm looking at is all of the purple nuclei that are present in this B panel that are absent in the A panel. So all of these new purple nuclei have been recruited to the area. Panel C, just to the right, acute rejection, humoral rejection, so the blood response or a antibody-mediated response causing vasculitis with proliferating smooth muscle cells in the walls of the tubular network. So you can see this thickening of that smooth muscle cell layer. And then ultimately on the far right, panel D, you've got graft arteriosclerosis. So this is actually supposed to be wide open. You see this little sliver of white? This whole lumen should be white, and all of this material that's inside is smooth muscle cells and connective tissue that's found in the blood vessel intima. So you basically starve off the kidney that you've transplanted. So the first recognition is seeing the antigen, and the second rejection or the manifestation of those events as they play out, we've got antibodies, right, for the humoral side within the presence of complement, and we've got leukocyte recruitment. The CD8 positive T cells, back to this slide. So that's the CD4 positive T cells stimulating the lymphocytes. And then over here in the direct pathway, you've got the CD8 positive cytotoxic T lymphocytes causing cytolysis of a lot of these cells that are in the renal tubule network as well as the renal vascular supply. This is considered a type 4 hypersensitivity because of the involvement of these T cells. Remember when I talked to you about that? Like that's really kind of the hallmark recognition point that you're talking about type 4 hypersensitivity is when you have T cell involvement. We get thrombosis eventually. This will completely occlude, and you'll clot off this vessel. You get damage to the vascular supply of the graft being the kidney, then you have the death of the entire organ. Okay? Pretty serious stuff. Okay. So there's lots of different immunosuppressant drugs. Cyclosporin is just one of the older ones, one of the more classic ones. So let's start talking a little bit more about autoimmune diseases that'll set us up into acquired immunodeficiency diseases that we'll look at in the next lecture. So what is the pathogenesis of autoimmunity? Let me ask this question. How does it happen? Why do we have autoimmune diseases? That's my question to you. It's okay. It'll come back. Sometimes I have to leave the room, and then I remember what I came into the room to get. That happens to you now at your age? It gets worse. I'm sorry, but it gets worse. Starts with a C. Agreed. What do you want to help her out on that one? Central tolerance. If we're talking about B cells, it's just central tolerance. If we're talking about T cells, then it's what? It could be either central or peripheral tolerance mechanisms. So if we have a breakdown of self-tolerance mechanisms, like central and peripheral, then we're going to develop autoreactive clones that are out in the periphery. And they're going to do something that we don't want them to do. Okay? So we talk about clonal selection and central and peripheral tolerance first before we get into this part of the lecture, because you kind of have to understand how it works normally before it really makes sense to talk about some of these diseases. A lot of students just like, I just want to know about lupus, man. I mean, I have a friend that has it. It's horrible. I want to know about arthritis because my grandmother or my grandpa has it. But before we get there, we have to go in sequence. Okay, so now we're ready to talk about it. You get the breakdown of these self-tolerance mechanisms. Another way of saying that is that the immune system is leaky. These self-reactive clones leak into the circulation, and they really shouldn't be there. And more over time, we're seeing more and more autoimmune disorders. And we'll get to that here in a minute. So some of the triggers are genetics, and environmental. And we'll talk about these even in the next lecture. But some of the environmental triggers, right? As time moves on, our environment has become more complex as a race, as a species, not less complex, right? We have new chemicals that we are responsible for making, right? We have atomic energy, and there's a side effect of generating atomic energy, right? You can say we have atomic weapons. Yeah, I was going to try to not go political, but you're right. Okay. I mean, post World War II. I mean, we didn't. We'll just go there for a second. The U.S. really didn't know what it was getting itself into when it dropped 2 nuclear bombs on Japan. And then all of the following decades, there was all this discovery of, oh my goodness, what did we do? Okay. Well, that story is like not a new story as a human species. Like, we've been doing this for a long time, right? We made the automobile in the 1800s, right? And now it's bad for the earth to have a combustible engine, right? So now we're making all these electric vehicles. Want to bet there's going to be some problem that we don't know about now, decades from now, with all these EVs? I'm guessing there is. I don't know what we're going to do with all those batteries, right? I mean, the battery in your car is like this big, right? If you have a combustible engine. Even if you have a really big combustible engine truck, maybe you have 2 of those, one on one side, okay? But if you have an EV, the whole floor of your vehicle, which is like 4 feet by 8 feet, is pretty much batteries. So we're gonna have a lot of leftover batteries that don't have a purpose here in a few years. So we've been doing this environmental thing for a while. UV radiation, chemicals, pollution, all of these things can cause breakdown in self-tolerance mechanisms because they can cause mutations at the level of the DNA. We'll talk about that in the next lecture of like where this comes from. So we have genetic susceptibility, or we have environmental, triggers. We get failure of the self-tolerance mechanism. So we release these self-reactive lymphocytes, B and T lymphocytes. They get out into the circulation, and they start targeting very specific tissue that we normally need and we normally want. So the first one up that we're going to talk about is systemic lupus erythematosus, or SLE. It's a very debilitating disease. So this is the lupus that's the worst of the categories. So there's 4 different types of lupus that we've categorized. We've got the SLE, which is this one, kind of the worst. And then all the other ones kind of fall in about the same tier of severity. So we've got cutaneous. Cutaneous is like skin. We've got a fetal version. We've got a drug-induced version. And cutaneous, sometimes another name for it is skin lupus or discord lupus. And the modification happens at the level of nuclear proteins. So the nuclear protein itself is the antigen. So the cell itself is seen as being foreign. So this activates T and B lymphocytes and causes these immune complex and autoantibody mediated tissue destruction. So this is a type. Which one is this? If we have an antibody and an antigen complex, and then it starts circulating around the body and depositing different places, which one is that? 3. That's right, 3. So systemic lupus, gross observations of this young patient. So very classic, what's called a malar rash, or a butterfly rash. You can see it across the bridge of the nose, and then it dips down onto the cheeks. So that's having skin lesions, right? That's a subcategory of lupus, is just the skin or the discord or the cutaneous version. But in SLE, you get a lot of these antibody antigen complexes that get trapped in the skin, and it creates these lesions. These patients tend to be very photosensitive, meaning that it gets worse with exposure to sunlight, which should make sense because that's a mutagen. UV light's a mutagen, and so this can be exaggerated under extreme exposure to sunlight. The other aspects is we've got what we refer to as acute necrotizing vasculitis. So we get lesions that get trapped in the blood vessel. That should make sense based on Tuesday's lecture. We get these complexes that get trapped in the joint. So we get joint swelling. We have like arthritis-like feelings in the patient, pain and discomfort. The skin erythema we just covered with this malar rash. We've got glomerulonephritis because it gets trapped in the filtering organ of the body, the glomerulus. And then last but not least, we've got what we call central nervous system involvement. Because you've got vasculitis, the CNS is very dependent upon blood flow, and there's a microarchitecture that perfuses the central nervous system ultimately to cerebral spinal fluid. So if you compromise that blood flow, you'll have clinical sequelae. So this one's pretty serious. This is a pretty serious autoimmune disorder that does manifest it, unfortunately, manifests itself pretty early in life, which is why we have a picture of a pediatric case. Rheumatoid arthritis, not reactive arthritis. This is rheumatoid arthritis. So rheumatoid arthritis, let me set it up this way. Rheumatoid arthritis has the involvement of an arthrogenic agent thought to be collagen 2. So collagen 2 is the alleged suspect. Okay, you develop autoantibodies against your collagen 2. You have some involvement at some level with helper T cells, but most of this is an antibody-mediated reaction. So hypersensitivity, which class is this one? Most commonly presented. You have an antibody-antigen complex that floats around and gets stuck in the joints. What is that? Type 3. Now, it's debated. You might see this in the literature, and I'll have to look back at the film. I think I might have misspoke on Tuesday because this is debated as a type 4 hypersensitivity. Some textbook classify it as a type 4, others classify it as a type 3. Most commonly, it's referred to as a type 3 because of the antibody-antigen complexes that float around and get trapped in the joint space. But it's not uncommon for you to hear some professors on some days say it's a type 4, probably me on Tuesday, if I remember correctly. But we're classifying it as a type 3. I won't have a trick question for you on the exam. It's not meant to be trick. But I want you to understand that sometimes someone might argue with you that it's a type 4 because of the T cell involvement with the helper T cells. So what's happening here? We've got our antigen and the question mark. I mean, this is from a textbook. So what I told you is the usual suspect is collagen type 2. You've got an MHC class 2 that is, seeing sort of this antigen, displays it to helper T cells, which is why we sort of see the literature and those in the camp of this is a type 4 hypersensitivity because of T cell involvement. But those T cells, the whole role for them is to trigger inflammation and to recruit B cell activation to start making these autoantibodies. Now they get trapped in the joint and you start getting what we refer to as a pannus, which is an area of inflammation in the joint space. An area of inflammation in the joint space. Simultaneously, we're activating these macrophages, recruiting them into that area, which leads to aggressive pannus formation being propagated. And then you can see that endothelial cells get activated in the bloodstream. And so they express adhesion molecules to upregulate the ability of monocytes to recruit macrophages into the periphery because that's the pathway of normal inflammatory cell recruitment. So what does this look like? Rheumatoid arthritis, joints, you get synovial destruction. This is a diagram that on the left of this diagram, you see this dotted line. This is what the normal joint is supposed to look like. On the right of this dotted line is what a rheumatoid joint looks like. And so I don't want you to think that a rheumatoid joint only has this pannus ingrowth of inflammation on one half of the joint. It's the whole joint. This picture is just trying to illustrate what it normally looks like on your left to what pannus inflammation looks like on your right. Is that clear? Cool. If you look at this diagram, we see the infiltration of macrophages, plasma cells, antigen-presenting cells like dendritic cells. We've got like B cells, helper T cells that are here, neutrophils that are also present. So there's a whole lot going on. It's a giant party. Everybody's there in rheumatoid. If you look at the histology, all of the purple, and you can see it in higher magnification, all of the purple dots are these nucleated cells that are in that pannus of inflammatory stroma of the synovial space. So if it's in the skin, on the far right is a picture of skin lesions, and what you're seeing there are these little rheumatoid nodules. So these rheumatoid nodules are highlighted in this red arrow, where you get these collection of lymphocytes in the tissue. If this happens in the blood vessels, then you get these obstructions, or what we refer to in last lecture as vasculitis. So a pretty aggressive issue associated with rheumatoid arthritis. And if I told you on rheumatoid arthritis, this is a type 3, and some actually refer to this as a type 4, because of T cell involvement, the helper T cell involvement. And so that's sort of an argument that happens in the field. What is not an argument of what's taking place is the organs that are affected, like skin, joints, and blood vessels. In the joint space, like when we look in the hands, so you can kind of appreciate these areas, these lesions. So do you see like this hot spot right here that's highlighted in red arrow? So this white area is a hot spot. That's lighting up areas of extreme inflammation because there's a lot of fluid in that joint space, and that's why it looks white. Whereas if you compare and contrast that to like these joints in the left hand, this is relatively absent of that inflammatory reaction. In extreme cases, if you zoom in here, you can see that inflammation is starting to erode the bone. Do you see this little like pit? That pit in the side of the bone. So it can be episodic, meaning it can flare up under certain circumstances, like in times of high stress. We'll see that play out in the next lecture, what stress level does to the immune system. It actually suppresses it. It triggers it, but then it makes you sort of immunocompromised. It tends to affect the small joints first. So that's why you see patients that have like these really crooked hands. And it's bilateral because osteoarthritis can affect like, a former pitcher's arm, or a quarterback develops osteoarthritis in their throwing arm. Okay, you might develop osteoarthritis in one knee or one hip, but rheumatoid arthritis is bilateral because you're circulating this inflammatory response throughout the vascular supply. So it's usually a bilateral, or it's symmetric is what we would refer to it as. And there's this rheumatoid arthritic factor that they've been able to identify in about 80% of cases, and that's that collagen type 2. So what's happening in the other 20%? We don't know. We don't know why there must be some other atherogenic agent that's causing the problems. The second word on that list there, ankylosis. So ankylosis is where the fingers and the joints bend. And so that's a word in the Greek that means bent shape, ankylosis. So, summary slide, like I promised on Tuesday, out of a different textbook, but I think it's a really nice study tool because you can see type 1 in the second column, type 2 in the third column, type 3, and then type 4 in the far right column. And you can see some various characteristics. Like if you look at the characteristics of type 1, 2, and 3 antibodies, you get antibodies being released. In type 4, in the classic type 4, you don't have any involvement in the antibodies, so it says none because it's a T cell mediated response. If you look at the let's look at the histology. You'll see at the histology level, you've got basophils and eosinophils in type 1. That's the allergic reaction, so they degranulate. That should make sense. You've got in type 2 under histology antibody and complement, which makes sense because it's a humoral circulation and you're stimulating inflammatory event that's taking place. If you look histology type 3, we've got complement and neutrophils. Also makes sense. Those neutrophils are located in some sort of joint space, or they're located in the glomerulus for glomerulonephritis, or in the wall of the blood vessel. And then if you look at the histology on type 4, you see monocytes and lymphocytes. So transferred with antibody for types 1, 2, and 3, transferred with T cells for type 4. Again, there's always those that are kind of the gray zone, right? That are debated. But I think this chart will be a decent chart for you to be able to keep an eye on. So if you look at the examples, like a lot of these we gave, like allergic reactions, allergy-induced asthma, hay fever, that's all type 1. Those are allergies, penicillin allergies, food allergies, allergies to bees or wasp stings, allergies to pet dander. Allergies to homework wouldn't fall into that category, but I understand, poetic license and why you would want to use it that way. If you look at type 2, some additional examples like Goodpasture's nephritis, which is a glomerular disease of the kidney. We also talked about type 2s being, what are some of the examples of type 2s that we gave in class? We talked about Graves' disease, and which other one? It was I chose the easier of the two to say. What's that? Not MS for type 2. Blood typing. There was one other one. What was that? Myasthenia gravis. Type 3 that we covered today, SLE was our big one. There is a type of lung disease called farmer's lung disease that's an autoimmune disease that targets the lung tissue. Poison ivy, poison oak, we talked about type 4. Today we talked about kidney transplants or liver transplants. So that rounds us out on autoimmune disorders. Questions? Is it possible to do localized immunosuppressant injections? It is. The challenge is local may not be enough because the organ, especially if it's like a kidney, the kidneys receive about 1/3 of all blood flow immediately after the heart beats. Because, the heart beats, blood goes, to the heart itself, then goes up to the brain. Then it makes the turn around the arch. And the first two things that come off right about here is the right and left renal arteries. And so a third of blood flow goes to the kidneys, and it's filtered like almost instantaneously. Like they're the second in line. The first in line are the head and the heart, the brain and the heart, and then the kidneys get everything else. So if it's a kidney transplant, for example, and you do local, you may be missing because you're putting blood, and those antibodies are going to circulate everywhere. Okay.